Welcome everyone to today's Schwartz Center Compassion in Action webinar, When Healthcare Heroes Need Help, Destigmatizing Mental Illness in the Healthcare Workforce. Thank you for joining us. I'm Matt Herndon, I'm the CEO of the Schwartz Center. As many of you know, we are a Boston-based nonprofit organization established in 1995 to advance compassion in healthcare. You might be familiar with our signature program, the Schwartz Rounds, which is offered in hundreds of member organizations around the world. Our work at the Schwartz Center has long been focused on partnering with healthcare leaders and providers to improve relationships of care and to foster healing healthcare systems, not only for patients and families, but for the healthcare workforce. And that's what we're going to talk about here today. In many cases, support resources are available, but in a medical culture that normalizes stoicism and often indirectly or directly punishes those who admit to needing help, they're often impossible to access. As we start to look toward and plan for post-pandemic recovery, we see an opportunity to do better for our patients and for our healthcare workers. That's why we've invited this illustrious panel to join us today to consider the steps we can take, that we must take, to make it possible and acceptable for those who care for us to get the necessary mental health care they need. I'm going to pass the mic to our host in just a moment, but before I do, I want to thank a few people and organizations who have made today possible. First, I want to thank the outstanding team at First Responders First, without whose support and inspiration this event would not have happened. Thank you, Deborah Marcus, Kasia Laskowski, and Megan Agnew. Thank you also to our panelists today, whose organizations represent some of the best thinking and efforts to imagine a more compassionate future for healthcare and for our healthcare workforce. Finally, I want to acknowledge that this Compassion in Action webinar series has been funded in part by a generous donation made in the memory of Julian and Eunice Cohen. So today's program will last about 60 minutes with a panel discussion for the first 40 minutes or so, which will be followed for some time for questions. Feel free to enter your questions in the chat or the Q&A pane throughout the discussion. And with that, I'll hand the event over to our moderator. I trust many of you will recognize him from his award-winning show on MSNBC, All In with Chris Hayes.
Hey everybody, how we doing? It's good to be here. Matt, I'm glad to be here with you all today. I gotta say, mental health is at the front of a lot of people's minds. I've been having conversations with a lot of friends and families amidst this pandemic January about people really having a hard time. So I think this is a really fitting time to discuss this. I want to welcome our panelists for today's conversation. We'll start with Jennifer Breen Feist and Corey Feist. They're co-founders of the Dr. Lorna Breen Heroes Foundation, whose mission is to reduce burnout of healthcare professionals and safeguard their well-being and job satisfaction. They're both attorneys. Corey currently serves as the CEO of the University of Virginia Physicians Group. Dr. Beth Lown is Associate Professor of Medicine at Harvard Medical School and Chief Medical Officer of the Schwartz Center for Compassionate Healthcare. Jeremy Segall is the System Chief Wellness Officer at NYC Health and Hospitals, the largest municipal public healthcare delivery system in the United States. It's an incredible system. If you or anyone you love has ever had to interface with it, he's a licensed creative arts therapist by training. And Dean Michelle Williams, the Dean of Faculty at Harvard T.H. Chan School of Public Health, Anthropoulos Professor in Public Health and International Development at the Harvard Chan School and Harvard Kennedy School. She's an internationally renowned epidemiologist and public health scientist. It's great to have you all here today. Maybe I would start with Jennifer and Corey on why this issue is important. I think that Matt may have said this before. I know the healthcare providers that I have in my life that are friends do actually tend to be kind of weirdly stoic and bravado-y, and like, even for lack of a better word, like macho, even though a lot of them are women, about this stuff. It's always striking to me, actually, how much they tend to downplay mental health issues and stuff. So I'm curious to just hear you talk about what the issue is and why it's important.
Hi, Chris. Thank you for having us. I can start with that and then pass it over to Corey. You know, Corey and I started this journey personally because of the death of my sister, Lorna Breen, in April of 2020. And I laugh when you say these people are macho. You're exactly right. And I believe that is the culture that they are brought up in. They don't start out that way. They get to be that way because they have to be that way professionally. And what we know and what we've learned about mental health in the healthcare profession is it's a pandemic onto in and of itself. Prior to the COVID-19 pandemic, we knew that physician suicide was twice that of the normal population in the United States. We knew that burnout, depression, anxiety is higher amongst healthcare providers than it is amongst people who are not healthcare providers. Then we add on to it this pandemic that's, you know, we're looking at a year right now. And these folks are continuing to work day in and day out. They're putting their own safety at risk. We're hearing stories all around the world. I just connected a couple weeks ago with a family whose a physician died in Canada. We're hearing stories from all around the world about how this is affecting people. And the issue is that the culture, the stigma in the healthcare industry is a real problem, and it's an institutionalized issue. The licensing laws are tough, the credentialing laws are tough, and it's time for us to change it.
Chris, I would add to it, you know, it'd be one thing if our healthcare professionals were starting this marathon in good shape. But as Jennifer said, the healthcare professionals in this country started from a position of being depleted from a burnout perspective. Many of them were already showing signs in nurses and in medicine of being burnt out. And so what you've asked this incredibly fragile workforce to do is to run this marathon for us without a clear finish line and just keep going. And we keep layering and layering on top of an already kind of broken workforce. And then the cultural pieces of not being able to take a break, not checking in on each other because of, as you described, that just cultural norm, which is reinforced, as Jennifer said, through all of these regulatory and, you know, whether they were all unintentional, I'm sure, and well-intended, but there are so many things that reinforce to the healthcare providers that asking themselves for help is a big no-no, and it's a career limiter and potentially a career killer. And so that's what we've got scaled across not just this country now, but also the world.
You know, I was having a conversation for a piece I'm actually writing with an ER doc who was in New York during that initial horrible period, and he said something. And Dean Williams and Dr. Lown, I'd love to hear you talk about this. That struck me as someone who's not in the medical field, which is, you know, in my head I was talking to him. I said, you know, before the pandemic, you know, it must have been pretty common that you would have to deal with a patient dying. And he said, not really, actually. You know, we were, you know, it wasn't actually that common. All of a sudden you have people who are not used to dealing with that, dealing with 5 or 6 or 7 a day, day after day after day. There was just a complete lack of architecture around us to deal with it, to deal with the grief, the emotion, the trauma of it all that went through. And I'd like to hear Dr. Lown and Dean Williams just to talk about the absence of that and how prevalent that is.
I can hop in here, Chris. Thank you. I think that this sort of self-denial comes in part from the culture of medicine that gets inculcated at the very beginning, you know, even in pre-med with its competitive nature, but extending well into medical school. Medical students start with the same levels of well-being as the rest of the population, but over time that starts to deteriorate and they start to develop burnout. So the whole process starts early in training. I have to say, I'm not sure maybe the word macho applies, but as a clinician, I would say that what draws us to healthcare is the desire to heal, to serve. And we are willing to put patients' needs above our own. And that's the positive side of medical culture, that sense of altruism, that sense of dedication. And I call it love. We don't talk about love in medicine very much. It's like a dirty word, but it's a boundaried professional love that we feel that drives us forward. And it's those things that really give us the joy that we have in our work and keeps us going through hardship. But I do think that's also been exploited and taken advantage of in terms of the demands for work and work hours and productivity and the like. But I think it is a cultural problem. It begins early. It's sustained over the course of training and well beyond. Just one more thing, and then I'll turn to the dean. I was reading some recent stats. Before the pandemic, burnout was at rates of maybe 35, 45% of nurses, 45 up to 50%, a little bit more depending on the specialty and docs. And now it's at about 60%. And those stats are kind of staggering because that is associated not just with sapping of the soul of clinicians and intention to leave the profession, but it's also associated with medical errors. So it has negative consequences for everybody.
Let me just add that from a public health perspective, in addition to the physical strain and stress that healthcare providers encounter during times of epidemics and pandemics, and I have to confess to you, I'd been haunted by a question: who cares for caregivers? Since the 2012, 2014, 2016 Ebola outbreak in West Africa. Because there we saw an incredible amount of physical and mental stress brought to bear on healthcare providers. And we knew that the next pandemic was going to be coming. It wasn't a matter of if, it was when. And while we were all struggling with this high prevalence of burnout, high prevalence of under support for frontline workers, particularly in hard hit communities with lots of health disparities, the fundamental question was, who cares for the caregivers, the individuals who run towards when most of the rest of us are retreating? And we had to realize that we have to take a whole human approach, that not only their mental health needs, but their physical needs during times of pandemic were not being met by the institutions that employ them. Many of the institutions were being crushed themselves institutionally. And so we felt it was really important to prioritize building resilience and calling attention to this under stress workforce that was going to be called on during a crisis that has unfolded and is now running into 12 months.
I wonder, Jeremy, if you can talk a little bit about the sort of intersection of, people keep talking about the cultural aspects. There's other, Corey talked about regulatory aspects, like how the sort of on the ground obstacles manifest themselves.
Yes, thank you so much, Chris. And thank you to the Schwartz Center for having me. It's a pleasure and a privilege to be among such incredible colleagues and peers. So to speak about the intersectionality of all the multi-factors that play into the stress that a healthcare worker, and I want to say this, both clinical and non-clinical, often when we're talking about the landscape of healthcare and the term first responder, we really have to remember that that definition has really changed, specifically throughout COVID-19, right? This is the largest public healthcare emergency in our lifetime, on top of it, a mental health crisis, and it is impacting all of us. There are unique stressors working across the landscape of healthcare, no matter what your department or discipline, right? So there are regulatory issues, there are licensure questions that often make people afraid to really speak up about their emotions. The cultural aspect of needing to be stoic at work is partially because that's a psychological defense mechanism, right? If you are dealing with mortality and morbidity on a day-to-day basis, you have to compartmentalize it sometimes to be able to go home to your families, your roommate, your loved ones, your pets, right? So it's something that we are taught and trained to be able to handle. But day to day, right? We all put on our blinders. We all have tunnel vision. The idea is to go to work and to either support the care of a patient, to support a supporter that is caring for a patient. And that looks very different depending on what your role or discipline is within the landscape of healthcare. But the thing that we have to remember is that we are holistic entities. The day and age of separating your personal self from your professional self, times there are changing. We have to be able to take into consideration that we are human beings first. And it's really incredible to see that across the landscape of healthcare, across the nation and internationally speaking, we're starting to take more into consideration the well-being and resilience of our staff members to deal with the day-to-day operational challenges of getting patients into beds, getting the care that they deserve, getting their medications on time, making sure that there's person-centered approaches, right? Making sure that we're collecting quality data, making sure we're meeting all the regulatory requirements to keep the doors open, right? So unfortunately, because of our day-to-day practice, the last thing we're thinking about is how am I feeling right now? We haven't been given the opportunity. And also in the past, we didn't necessarily prioritize. We didn't see the executive as well as institutional buy-in and support of wellness and resilience programming, right? The well-being of our staff means that the healthier that our staff are, the healthier the health system is, so that we can care for patients at a higher quality and standard of care and continue to serve the communities that need it the most. So, you know, I can't really speak to the variables that each institution or system really deals with. It really looks different depending on the size of service, the complement of staff, the population served, the service lines. Is this ambulatory care versus emergency department versus inpatient or behavioral health services, or even community care? We can't forget that we have a lot of healthcare workers that are going into the homes of patients that need support right now, also dealing with the environmental factors of COVID, taking mass transit, going into a stranger's home, thinking about the safety, not only because of infection prevention standards, but also their physical well-being, entering into new environments that they've never been in before. So I can't really speak to the pinpoint issues that each individual is taking, but what I can say is that because times are changing, because we've seen this impact, we're starting to see more emphasis and investment in the well-being of our workforce.
I wondered if maybe if Dean Williams and then Dr. Lown can talk a little bit about, because you were talking about this before, Dean Williams, about what the sort of status quo was even before COVID, the degree to which this was sort of a dawning awareness among practitioners, administrators, and educators that this was an issue even before we hit this, and what the actual kind of status quo ante looked like in terms of incorporating sort of proactive measures to be dealing with mental health in sort of practical settings.
Yeah, thanks, Chris. You know, I think we were before COVID, during peacetime, not all of our major institutions, but some in the vanguard were beginning to take institutional responsibility in creating positions like chief wellness officers, who were taking on the institutional role of looking at the work environment, looking at the structure and the workflow, and beginning to say, how can we as an institution, you know, change the way we support and model behavior that is consistent with health and wellness. And it meant bringing down barriers. And it means that we need to bring forward models that take an institutional as well as a legislative and employee workforce centric approach to understand how best to bring the science forward to protect and promote health and wellness. On the legislative side, we have a lot of work to do, because we know, as Corey and Jennifer identified, that currently we have policies and systems in place that add the burden and stigmatize healthcare providers for engaging in seeking healthcare, mental health care. And so there are systematic approaches that have to be taken. This is not about telling people that the locus of control is just in their own hands, but we have to engage policy as well as institutional leaders, employers, in looking at what the physical process barriers are to supporting health and wellness and sustaining our workforce. And it also has to include the educational system, because right now, medical students, residents, and fellows are experiencing these strains at disproportionate levels, and we are seeing a leaky pipeline.
Dr. Lown, you to more charitably sort of rephrase that point before. I mean, I think if this value, which is sort of beautiful in many ways, of kind of self-abnegation, right, of self-denial and in the service of others, that is so profoundly inculcated in that pipeline. I mean, I just knowing the people in my life who went through med school, like it's part of the thing, right? It's that you've worked these crazy hours and you've slept so little and you've been on your feet and you've been doing this. It's like how to sort of separate that out, that value from, you shouldn't ask for help and you shouldn't be checking in on those things.
Yeah. I now also want to comment on proactive measures to guard our mental health. Because honestly, until it is truly valued and it's prioritized and modeled from top down, bottom up, sideways, it's not going to really happen or be sustained. Before, the pandemic, the crisis had a burnout had reached such a proportion that the National Academy of Medicine convened a task force to create a consensus report that was issued last year to make recommendations about how to take action against clinician burnout. And they had 6 key points that I'll just mention. They mentioned the need to create a more positive working environment, just as Dean Williams has just said. And they have sub-points suggestions under each one of these. Also to create more positive learning environments. They point out the need to be able to track, to measure, to create centralized databases so we really have a handle on what is happening, because right now it's kind of piecemeal across the board and we don't have any centralized ways, excuse me, of keeping track of this. And then I think, a key point that we have got to grapple with is the administrative burden that is being imposed upon the workforce. So, for example, I'll just mention that there are requirements to enter everything through the medical, record, of course. But there are so many requirements in terms of administrative regulatory policies that we have to adhere to, quality measures we have to be able to document and report and actually carry through. We have, prescription pre-authorizations that I think if you polled clinicians, physicians, that would probably be one of their number one peeves. All of this takes tremendous time, and it's not the work we want to be doing. The work we want to be doing is connecting with our patients and their families. So we really need to look at all the legislation, all the policies, all the requirements. Are all of these really necessary? What can we streamline? What can we integrate if they're necessary with the electronic health records? So you don't have to jump back and forth and spend 2 hours at home at night in your PJs trying to complete your charts and so forth. These are major issues that aren't up just to a single organization.
Can I just ask one follow-up, Dr. Lown? Just when you say burnout, if you could just give, I think I know intuitively what that means, but to the extent there's any kind of consensus definition.
There is. So mostly it's been defined by the research instrument by which we measure it, which is the Maslach Burnout Inventory. So there are 3 key domains, and the first is emotional exhaustion, just depleted. I have nothing left to give. The second is called either depersonalization, meaning treating people like objects, or cynicism, like detachment and just not caring. And the third is a low sense of sort of self-efficacy, not confidence, but the belief in your ability to actually accomplish what you want. Those are the 3 measures that we follow. And I think the ones that are most true to clinicians are really the depersonalization and emotional exhaustion domains. Nurses really the research in nursing is mostly about emotional exhaustion. So that is the definition of burnout.
Thanks so much. That's very clarifying. Jeremy, I wonder if you could talk a little bit, and then I want to come to you, Corey and Jennifer, talk about some of these obstacles. But what, the degree to which, as things are changing, like what resources have come online in places, or things that interventions we know do help, or things that people are trying or piloting in that space?
Absolutely. That's a fantastic question. Kind of piggybacking off of what Michelle and Beth were just speaking about, right? There are systemic barriers that have to be addressed, both on a national, state, and city level. But then we also have to take a look at it from a systems perspective within the healthcare entity or institution itself, looking at it on a individual basis and what programmatic offerings can we offer to holistically support and help build strength and resilience within that workforce member. Then you also want to take a look at unit-based strategies. So really looking at treatment teams together, the environment of care in which people are actually working in, to see if there's any specific interventions that can be offered to the workforce at large within that hub, if you will. And then continuing up the ladder, if you will, looking at service lines, depending on the care setting, and then the entire facility having a facility-specific action plan or approach to well-being, right? So we never want to blame the victim. We never want to say, as Michelle was saying before, the locus of control is always on the individual, right? You want to create a push and pull approach so that there can be safety and trust built into the approach, so that the workforce member can approach those resources on their own accord, but then we're also trying to reduce the psychosocial stressors and burdens that they are experiencing during their workday as well. So it's administration's responsibility, it is management and supervisory levels responsibilities, and the individual themselves, as well as the nation. Nobody owns wellness, right? So I'm a licensed mental health practitioner, right? So great, I'm used to working through the mental and emotional supports that are necessary to engage our workforce and ensure that they feel that they continue to serve and follow through on their duties. But that doesn't mean that I own wellness as the chief wellness officer, right? We all have a part to play in the system's well-being to care for and support patients. And it first starts with caring for your colleagues and your peers. So things that we know that have really been working, that we're starting to see bubble up internationally, nationally, taking a look at that holistic approach again is really looking at physiological opportunities to support sustainment and nurturance of the workforce. So if that means being able to serve them meals, if they're working arduous hours, back-to-back shifts, unable to get off the floors, to really make sure that they have basic necessities such as food and water to hydrate, right? Caffeine goes a long way these days. Right? So aside from physiological well-being is programming, right? Something that we need to continue to remember is that our healthcare workers were contracting COVID at the beginning of the surge in New York City, right? So many of them are long haulers. Many of them are continuing to have signs and symptoms of COVID-19 well past having the infection themselves. So you have people with reduced lung capacity. You have people that are really continuing to have migraines and headaches and that really are feeling lethargic. So it's about, is there an opportunity to provide them in a manner in which that they can engage with physical activities during their shift, during their breaks, after their shifts, walking groups, chair yoga exercises, webinars that they can download and see on their smartphones during their breaks or on their commutes, right? So moving around, we also know that debriefing principles are exceptionally important in not only impacting the culture that was addressed before by Jennifer and Corey, right? To really break through the stoicism, or to be the stoic environment, if you will, of the model of medicine, right? To start opening up to say, it's okay to not be okay. That doesn't mean that you're not fit for duties. And emotions can be scary at times, but you are larger than your emotions. And there's opportunities for you to find a shared mental model or a shared narrative to begin healing yourself, but healing others through sharing stories about what's been challenging, but also what's been working for you. How have your coping strategies and mechanisms really been working for you? So debriefing doesn't have to just be about a medication error, a wrong side surgery, or maternal child loss due to human error. Emotional debriefing can be what's going on, how does it feel to head into work? And the things that we also have to remember that really have an impact on our workforce is that we live in a post-George Floyd world. We know systemic racism exists. We know that it's been perpetuated for years upon years upon years, right? We need to be able to look at complex traumatization of what's going on in the environment surrounding the election, surrounding the insurgents, surrounding all that we are as human beings and are facing day to day. We bring that that to work as well. So emotional debriefs has an opportunity to create a safe container, a framework for us to connect with each other and to speak about what we're carrying into work, but also out of work, so that we can go home and have the sanctity of support with loved ones. We also do know that proactive wellness rounds is something that has really been very beneficial. And this is something that does not have to be conducted by a licensed mental or behavioral health workforce member. There are ways to learn empathy and compassion building skills, to be able to actively listen to another, to reflect back and be the mirror, to be able to share in roles that we play and how we experience things, so that it can be opened up and talked about, right? And so that we can have a proactive opportunity to test the climate, to really see how does the environment of care feel right now, and what resources can we send directly to that unit or that individual, and or what can we continue to promote and crowdsource, so that we can continue to create systemic opportunities for initiatives and projects that can further benefit the workforce. We also know that wellness and respite or resilience rooms have been exceptionally popular, just to get a little bit of a moment to breathe and step off the floors, to pick up a protein bar or a bottle of water, right? Coordinating in-kind donations. So thank you to the community members out there that have really been supporting our frontline workforce members, again, clinical and non-clinical, those that step onto the floors to make sure that our families and loved ones are taken care of, right? So those rooms to present care to them as well, and making sure that debriefing can happen in those spaces, or that they can just go to relax and support themselves in a moment, getting the reprieve that's necessary. We also know education, as Michelle was just talking about before, just-in-time trainings, something that any pedestrian can open themselves up to learn in terms of how to use emotional intelligence, how to talk through, how to support someone during a panic attack, how to ensure that there are hard and soft skill sets that we can continue to develop and nurture, so that people can feel more equipped to reach across the aisle to say, how are you as my peer or colleague? What can I do for you? And to feel equipped to be able to do so, but to also learn better coping strategies for themselves. So those are just some highlights that we do know have been very beneficial. And I'll just say one last thing, learning from our US Department of Defense. We've learned a lot about the battle buddy support programming that our troops are offered. Often it's mandated, but right, we're seeing healthcare institutions be able to start pairing up like-minded or like-experienced individuals, really taking into consideration all the social locators, including race, ethnicity, religious beliefs, sexual orientation, gender identity or expression, right? To pair up healthcare workers in a very informal, confidential, laid-back environment where they can connect with each other and provide mutual peer support. So those are just some things that NYC Health and Hospitals has really been embarking upon, as well as many other healthcare institutions across the nation.
That's fascinating. The battle buddy model, which is a really interesting one. I wonder if Corey and you and Jennifer can talk a little bit about the actual legislative, when Dean Williams talked about legislative obstacles, there's questions in the chat about this, just about people having reticence, right? That if they're coming forward and saying like, I have a substance issue, or I am struggling with depression, that's going to have repercussions for their ability to work. What are some ways in which those serve as obstacles now? And what are some sort of, if there's discrete reforms in that area that we should be thinking of?
Chris, thanks for the question. And as Jeremy indicated, I mean, there's a lot that needs to happen in these institutions that goes well beyond what our needs are for the legislative front. I mean, Beth and I were interviewed last night, and it's kind of like, do institutions need to wait for legislation just to do the right thing effectively? And the answer to that, of course, is no. But beyond that, and so more to that point, as Jennifer and I have said in numerous forums, what we don't need here is stronger canaries. We need to redesign this coal mine. And when we do that, we need to do that from the outside in. And so as we think about it from a regulatory perspective, we start at the federal level, and there are a lot of there's federal help that can come to bear. And one of those is just sharing best practices across the industry to say, these are the things that you need to look for when it comes to stress, burnout, those sorts of things. And as we've talked about, all this starts early. So the legislation that we actually have proposed, that Senator Tim Kaine and his bipartisan group are carrying forward, touches on this early and often. So we get them early from those perspectives, and then we try to bring programs into hospitals and health systems to take care of our caregivers through their entire careers. So you've got kind of this need of education that can be done at a federal level. From the perspective of these questions, the questions around mental health not only can be asked when you apply for your license, and that's regulated by the state, they can be asked when doctors apply for malpractice insurance. They can be asked when doctors apply to be credentialed in hospitals to go work at a hospital. They can be asked when doctors are applying to be paid by insurance companies. Some of those insurance companies are governmental, so we can look for questions there. And there's a governmental fix. Some of them are commercial or private, and we need to go that way as well. But each one of those levels needs its own intervention and its own evaluation. And because of the fact that it is completely decentralized, as evidenced by those different layers, we've got to kind of take layer by layer, state by state, evaluate their questions, and make sure that they're appropriate. No one here would say, I don't think anyone here would say that it is inappropriate to ask a question about mental health. It's just, first of all, what is the scope of that question? Are you talking about impairment, or are you in your inability to provide care, or are you actually talking about, did you get divorced a few years ago and seek counseling? Two totally different things. In addition to that, what I've heard from many clinicians is sometimes the questions themselves, Chris, are actually cohorted on an application right by those questions around your criminal background. And so there's a whole reinforced message through this entire process, whether it's you're applying to get malpractice insurance or work at a hospital or work in a state, that getting help, formal help, is not acceptable, and it can have negative repercussions. So that whole issue is it needs to be peeled back one layer at a time. And so everyone has a role here in addressing it. Our federal legislation will start that conversation. Senator Tim Kaine has been amazing to champion this legislation. And what he's told us recently is, we're not stopping with this legislation. We're going to work layer by layer, step by step, to really try to get at this at the root, so we can eliminate as many of those variables as possible, and get the health, change the culture from the outside. Then it's up to our healthcare systems and our healthcare providers to do the work on the inside of the organization.
We're gonna, I think, take some questions from the chat in just a few minutes, but I just maybe before we do that, if folks want to chime in, maybe Dean Williams, Dr. Lown, Jeremy, about just areas in which there is change moving in the right direction, which is on sort of Corey's point there about the work that Tim Kaine is doing. If there are places in which the shock of the pandemic, not peacetime, to invoke your phrase, Dean Williams, has at least had the effect of getting people, focused on this.
Chris, let me start. I would say that, one of the silver linings, or one of the collateral benefits that we can gain from, the pain of the last 12 months, is the fact that teams are coming together, that academicians, practitioners, policymakers, philanthropists, corporations are coming together and rallying around this very important issue, which is ultimately a global public health issue, because we need a healthy workforce. We need to practice and model what wellness and mental health care and wellness means. And so we, I think, can try to keep working together at the pace we're working, which is faster than if we were not facing this pandemic, mobilize all of our assets across all sectors to really engage in dealing with these structural systemic barriers to mental health and wellness. If we do this, we'll all benefit. The healthcare providers will benefit, the unpaid informal workforce, people who are doing care in their homes and they're not part of a particular institution will also benefit from this. One last thing I'll say, it has to be a public health mandate that we have the right amount of data, because if it's not measured, it's not going to get addressed. And I think if we're going to keep pushing and promoting policy and evaluating the impact of those policies, we're going to need better data systems. So these are some of the collateral benefits, I think, that can come from the conversations that we're having and the partnerships that are coming together.
Thanks, Dean Williams. I would absolutely agree with what you said. I also would point out that mental health has never been regarded on par with physical health. It's not been prioritized, it's not paid for in the same way. And despite some laws about parity in payments, it doesn't exist right now. Also, that the whole, and you know, and can speak to this better than I, Dean Williams, but I think one huge realization has been how we have neglected public health, the health of the public, and how underfunded it has been, and how that has to completely change. And I agree with making mental health and this whole issue of the well-being, the health, the psychological, the holistic health of the population has to be a key priority. And I'm a little bit more hopeful now than I've been in recent years. I would also I would be remiss if I didn't talk about the Schwartz Center's programs. I've got to just tell a little bit about that because I do think they're a powerful force for change. And as some of you may know who are on this webinar, Schwartz Center has been offering programs for 25 years or so, and our signature program is the Schwartz Rounds. And these are facilitated, structured conversations where people can get together, whether you are the chief of surgery or in environmental services, doesn't matter. We consider everybody a caregiver, can get together and talk about the emotional impact on us of taking care of patients and families. It is a place, probably the only place, for open, honest, authentic conversations about our emotions and our reactions to our work. So it normalizes and validates and supports absolutely everything that we've been talking about here today. It's a very, very important program. It's spread organically across the world and is being offered in numerous organizations, systems, and countries at this point. So I think it is a force for good. The other thing that I want to point out that we are doing is very early in the pandemic, and in fact, in March, we started offering webinars on stress first aid. And we partnered with the National Center for PTSD to shine a light on those programs and the work that the military had been done in operational preparedness to support the well-being of their soldiers. And we have adapted many of the principles, the core precepts, and all of the strategies, and are now rolling out a stress first aid program across our membership. There's been tremendous interest in this. Stress first aid is a self-care and a peer support program that we are teaching. I think the last point I want to make is that we know that healing happens in the context of supportive relationships. And we just have to put that in front and center. Everything that we decide we want to do, every question that comes up, every change we want to make, we should really say, how is this going to support healing relationships between us and our patients and families, amongst us and our coworkers, with leadership and with our communities at large? I think that really has to be the gating question. And when we are able to say, we have removed and addressed the barriers to connection, to compassion, to empathy, and we are able to offer these kinds of healing relationships, I think we will see much of the burden of burnout recede and the joy in work flourish.
To add to a few other things, I do think we are going in the right direction. Obviously, it took a pandemic to really try to accelerate this for our nation, but I wouldn't be sitting here in front of you and on such an esteemed panel as a chief wellness officer. So, NYC Health and hospitals, in addition to many other healthcare systems across the nation, are really starting to identify these roles and making it a priority. We're seeing a lot of healthcare institutions start to add resilience and well-being measures or metrics to their governing body structures to be really measuring emotional debriefs or activations for support, so on and so forth. I really have to also say how I know it's going in the right direction is to see how the communities surrounding our hospitals banded together to support us, right? So something that we have to consider is, right, it's hard to just be a human being during a pandemic, let alone a parent, right? So you had all of the remote learning challenges and child and elder care issues. And so you really started to see healthcare institutions be able to come up with innovative approaches to be able to reduce some of the burdens of that. And in addition to respite hotels, so that we do know that one of the largest stressors, specifically on behalf of NYC Health and Hospitals from our staff wellness survey, right, 73% said that the primary stressor was the concern of contracting COVID themselves, but more importantly, spreading it to a loved one. So ensuring that we had safe spaces for staff members to go to, so that it wasn't just adding an additional stressor as they were leaving a already stressful day at work. Another thing that we're really seeing, which I know is in the right direction, is adding equity, inclusion, and well-being to the value systems of the healthcare institutions. We're seeing this start to bubble up as a social contagion, if you will, to ensure that we're starting to have deeper conversations and holding all executive leadership responsible for the well-being and resilience of the workforce, and to make sure that it's not just a checkbox, that it's something that's continued to be talked about and supported, both investment of time and money.
We have about 15 minutes here, so just wanted to get a few questions from the Q&A. This is an interesting one to Corey, Jeremy, and whoever else would like to answer it. This is interesting. How might we demonstrate to institutional leaders, e.g. large hospital setting, who are concerned about bottom lines, to demonstrate the value benefit of a healthier workforce?
I would love to, I'm sorry, I saw you about to go off mute, Corey, but this is something very near and dear to my heart, right? We always need the business case, and that's understood. But the approach here is, if our staff feel seen, heard, recognized, appreciated, and respected for who they are as a holistic entity, as a human being themselves, the more engaged they will be. The more engaged a workforce member is, the higher quality of care they will provide to the patients, which will equate to patient satisfaction. And so that's the business case. We do know that there are a lot of quotes out in the public domain that say, if you take care of the worker, it will take care of the company, which will then take care of the customer. So there's no difference in terms of well-being and resilience programming for our staff. The more that they are taken care of, the more that we can sustain and nurture them, the better that they can do their job and feel more freedom and courage to be their best selves at work.
Chris, I would add to that wonderful answer, Jeremy, by the way, that this is, I think, a strategic differentiator for healthcare systems now. Because if you offer and make an institutional commitment to the well-being of your workforce, whether that's by reducing the pajama time of your team members, by creating programs that reduce the amount of time that your healthcare providers spend doing bureaucratic work, or provide those kind of list of services that Jeremy has listed for us, I think what you're doing is you're setting yourself apart. And what that allows you to do is to recruit and retain the best healthcare providers. And if you're in the healthcare business, what you want is you want to provide the highest quality product. And so, as Jeremy said, there's a direct line between the burnout of the workforce and quality, but even more so, if you've got the best doctors and the best nurses and the best techs, then you can stand up there very proud and say, that's because of the best environment, and that's going to attract the patients. And at the end of the day, hospitals are in the business of taking care of patients. And the better your quality, the better you're going to attract patients. So I think it becomes a strategic differentiator for these hospitals and health systems to say, this is what I stand for, and this is how I prove it. And then they're going to see the workforce are going to vote with their feet, if you will, and they're going to go to the better providers. Because the reality is, from a compensation perspective, Chris, all compensation in healthcare is kind of benchmarked against national means. So it's kind of like everybody's making roughly the same amount of money, and people don't move generally for money. It's do you feel valued? What is that work environment? And so if hospitals and health systems can make that recognition and then start to turn their battleships, if you will, of these aircraft carriers, these big organizations, to actually change the environment, change the culture, support their healthcare workforce, they will have the best and brightest flocking to them and then staying for the long term.
Can I just hop in with a factoid? Sorry. It is costing us about 4.6 billion in societal costs that are related to physician turnover. And reducing clinical hours due to burnout in the United States. So if you need to make a business case, I think that's pretty powerful.
Yeah. Just one thing I would say, Chris, we have got to stop task shifting administrative work to healthcare providers. We've got to have a better electronic medical record system that is not such a burden to the talent. That has to be fixed.
Yes, absolutely.
I was
And
thinking,
as does the entire administrative burden. All of that has to be looked at in the policies about what we're required to do, what we're required to measure, and whether there's any data or evidence whatsoever to support that kind of work. That, again, it's administrative work. It's not direct patient care.
I've seen a few questions, someone talking about being an ICU nurse and the level of nurse burnout right now, particularly in the pandemic. And there's been a number of conversations about that. It's something that I've actually been covering a bit on the show as well. And I wonder if anyone had thoughts. Obviously, that we have healthcare workers from surgeons to people that are facility staff that are all in these facilities and dealing with different stressors of the pandemic. But nurse specific and nurse turnover in these institutions, and if there's anything specific on that.
I can address that first. Or Beth, did you want to go?
No, go ahead, Corey.
Just a couple pieces of national data that we're seeing, Chris. The nurses have it worse off than any group of healthcare providers right now, over and above everyone. We've participated in a number of panels like this with nurses, a lot of feedback. We were talking about the volume of death and dying, and we've got a burnout issue here, but we also have this moral injury and this injury that's happening by having the nursing workforce predominantly hold up the iPad so that the family can say goodbye, right? So they're not just an inanimate tripod standing there. There's a human there. And the layering of that injury and knowing that tomorrow I'm going to see more death and dying than I saw yesterday, and it's going to continue, that is taking a tremendous toll. And so just from a national data perspective, the nursing workforce is showing the highest degree of burnout of any of our areas of the workforce, which is why for our foundation, we have focused on the entire healthcare professional workforce, not just one segment, because at this point, it's all a team anyway that delivers the care, but they're all having this collective experience, and it's taking in a tremendous toll. The last thing I would share with you, which is really remarkable, it is one piece of national data that I've seen shows that people's feeling valued by their organizations is at an all-time low. The question that the American Medical Association is asking across the country in a coping with COVID survey, there are about 10 or 12 questions that are really spot on for today. But the one that I think just keeps resonating is, do you feel valued by your organization? And another question, do you feel more valued by participating in the care of COVID patients? Well, you might have thought maybe at the beginning of this, people probably said yes more to that second question, but now everyone's really tired, and the teams of care teams are just not feeling valued by their organizations. And that's going to lead to medical errors, and it's going to lead to an entire segment of our workforce just calling it quits sooner than they otherwise intended.
That's actually happening already. We have data around that. And we had a nursing shortage to begin with. On any given day, there are openings for 200,000 nurses across the country, and that was before the pandemic. So we are in trouble here in terms of, recruitment in the pipeline. I completely agree with you in terms of the nurses. The emotional devastation of having to hold someone's hand and FaceTime with a patient's family is so absolutely devastating. It's really hard even to grasp what that feels like. The moral injury also, I think, in terms of cognitive dissonance, the difference between what you believe, what you think should be happening, what you're seeing before you, watching either behaviors or having to enact behaviors that just completely go against your deepest values is very injurious and sets us all up for traumatic stress disorders. But, I think in terms of quality of care, making these end of life decisions that are hard, knowing that you have to make decisions, at times based on available resources, that in other days, you know, you maybe have making a different kind of a decision. That's heartbreaking. That trauma doesn't go away, no matter when or if we control the pandemic, God willing. Those feelings of moral injury, the cumulative burden of grief and loss. Everybody has lost so many people and many caregivers, at least 1,000, probably an undercount of caregivers have been lost to the pandemic. You know, all of that is going to weigh. But I also want to talk about this sense of being valued by your organization. After the Boston Marathon bombings, we ran a series of Schwartz rounds. And one of the astounding things that we heard at that time from those participants was the words administrative or leadership abandonment, that they felt that they actually were not being cared for, or that their emotions and reactions weren't important to the, you know, those who were trying to manage resources and lead the everyday operations. So, you know, that is a significant problem. And I think it's played out here as well. I know that everybody has done their best with the resources available. But it's really been a problem. It's really, all of these sources of trauma are going to linger. You know, and last thing I'll say, you know, there's this curve, sort of the trajectory of trauma that we know about from traumatology and trauma studies. And, you know, at the very beginning, people are sort of running into the fray. And then there's sort of a peak of heroism and volunteerism and idealism, and everybody is joining together. And then over time, that starts to go down, you know, wane. And I'd say we're probably right at the bottom of that pit right now. But there is something called post-traumatic growth. And post-traumatic growth is a complete possibility. We have to resource it, support it, start to address all of these needs for immediate support right now, and look into the future about what we have to do to support in the long run.
Chris, just really quickly, I want to say, you know, at a federal level, there is one thing that we have to correct. Right now, our Centers for Disease Control and Prevention does not include nurses and nursing as a specific category where occupational injury and trauma, like suicidal ideation, suicidal behaviors, suicide, are actively, appropriately being recorded and counted. And while it's done for other occupations, it is not done for nurses, and that cannot persist. We should not have a data capture system that leaves out this fundamentally important bedrock of our healthcare system.
That seems like a no-brainer to me. I'm not an expert, but I'm persuaded. I just want to thank you all. We're coming up here on the end of this, and I'll throw it back to Matt to wrap us all up.
Well, thank you so much, Chris, and to our panelists. All of you have joined us here today for this incredibly important conversation. The Schwartz Center and all of us are part of an important community, and it's a community that is really committed to making a change going forward in many of the areas that we discussed. So just a few closing points. As a gesture of our appreciation for being here today, please take a look at the chat, into which we've popped a link to a digital gift bag where you'll find some resources to support your mental health and well-being as we navigate these months ahead. And we hope that you enjoyed this Compassion Action webinar. Please keep an eye on your email for news of future events. And again, please take a moment to fill out the very brief survey we'll be sending you later today. We really appreciate any feedback you have on today's session. So thank you again for joining us and for your commitment to compassionate healthcare. Have a good day.